Good morning, everybody. Welcome to your weekly Sunday DMA IMA NDB Meet. Today, our topic is on fertility, and we have a very special guest with us. Welcome, Dr. Anita. She is a MBBS MD, obstetrician and gynecologist. Um, she is also the chairperson of Delhi Commonwealth Women's Association Medical Center and has over 35 years of experience in India and in overseas. Thank you for coming, ma'am.
Thank you.
Over to you.
Hi, good morning, everybody. We are missing Dr. Nidhi today, and at a short notice, I was told that I should be, by Dr. Veena, that I should be giving a presentation on infertility. But since I don't know how many would be interested in this topic after hearing to Dr. Nidhi, recently I had given a lecture to MD PG students in Jammu and Kashmir. So I thought, let me present the same presentation today and share some of the things with you, whether it interests you or not. If you find some interesting things, it's okay. Otherwise, just bear me out. That is what I would say in the beginning. So can we start? No, first one, first one, first one, first one, number one. Yeah. So how do we define infertility? A woman who doesn't conceive in the 1 year of her unprotected intercourse in the absence of any known cause of infertility is how we define when a patient comes to us that patient hasn't conceived in 1 year, though she didn't have any used any contraception, and we label it as primary. We label it as rather infertility. Next, what are the factors which affect fertility? There are quite few factors, which common factors I will mention. Number one is frequency and timing of sexual intercourse. The probability of the conception increases if intercourse is 3 times per week, but it drops when the frequency becomes 1 time per week. Obesity is the second factor which affects that. Obese people who are over 30 should are less likely to conceive, will affect their treatment success outcomes are also reduced. Next. Third, in continuation would be caffeinated beverages, though there is no evidence, but excess of everything is bad. Alcohol. Fourth, alcohol. Female patients taking small amounts of alcohol per week, 1 or 2 units, shouldn't be bad, but should be avoided, not taken as routinely. In West, you can't stop them. And intoxication may really affect semen quality, but taking small amounts may not affect our ovarian eggs from the ovaries. Next. Smoking is strong association between smoking and infertility in both partners. That is proven. Next. What are the chances of conception? People who are concerned about their fertility, when they come to us, we should be telling them that chances of for under 40 years of age, 80% of the couples in the general population will conceive within 1 year, and the rest will conceive in the second year. So cumulate without any, if they are using unprotected this intercourse without any contraception. Cumulative pregnancy in first year would be over 90 years. Next, who is at risk for female infertility? It is the age, hormone issues that prevent ovulation, abnormal menstrual cycles, obesity, underweight is equally bad, having a low fat content from extreme exercise is also bad, endometriosis, which we'll be discussing in detail later, and any structural problems they are present with fallopian tubes, uterus and ovaries. Next. Now, what are the types of infertility? Types of infertility, we make it in two types. Primary infertility means who have never conceived after 1 year of unprotected intercourse. And secondary infertility are couples, those who have become pregnant, lady has become pregnant, regardless of the outcome, what has been the outcome of the previous pregnancy, whether it was abortion, ectopic, but she has conceived once, that comes as, that we label as secondary infertility. Next. What are the common causes of the infertility which we see in females? We'll discuss first females, then males. The commonest causes, according to common causes, I have mentioned here: ovulation problems, tubal blockage, age-related factors, uterine problems, endometriosis, and I have mentioned previous tubal ligation also, because in a lady who thinks of getting remarried due to some reason, for her, if she has had tubal ligation, for her, when she comes, it becomes, we label as a secondary infertility due to tubal ligation. Next. Male infertility can be due to decrease in sperm count, then, or the sperms may be blocked from release. They are not being released properly. Sperms don't work properly in heavy alcohol use. Drugs can be a cause. Environmental factors where they are working, like occupation. We know heat is very bad for scrotal region and it reduces the quality of the sperms. And smoking cigarettes is the very, very bad, and any other medical diseases like diabetes, hypertension, where sperm male factors could be responsible. Next. Now in 33% about there are male factors responsible, 33 female factors, and in other 33 it is unexplained. But in unexplained, again I would say 10% would be combined male and female factors, and in others there's unexplained means, as it word signifies, that no, we can't find any reason. What is the reason in them? But they are unable to conceive. So how is a female patient, when she comes to us, how is she being examined? First of all, we try to see what is her ovulation reserve. For that, and ovarian reserving tests, for which transvaginal ultrasound gives us a big clue. Then tubal patency is the second test, which means HSG, hysterosalpingogram. Hormonal tests are also done, and rarely we may need hysteroscopy, laparoscopy, or any genetic testing. Next. Male infertility patient, male partners, main tests are done. That is, we do semen analysis, again hormone testing for him, then ultrasound of two types, which is done transrectal to check everything, and scrotal Doppler. If need be, they may also need genetic testing and testicular biopsy. Next. Just for the sake of semen analysis, I am just putting in a general that what we expect semen analysis, how do we expect? In each ejaculate, we expect 1.5 ml and concentration of more than 20 million, total sperm count above 50. Next. Motility should be minimum of 50% and viability 75%, leukocytes less than 1 million. If we find any abnormality, accordingly we label it that this is what is the problem with the semen analysis. If these criteria are fulfilled, we will be okay with this. Management. Next. So once we have investigated, done our diagnosis, basic workup, everything, then we have to manage. Management is first would be counseling and waiting. Counsel the partners, tell them about the cause, what is the cause and everything. Accordingly, the treatment will be given. And if there is unexplained, we can ask them wait, they should wait and give them the time when the ovulation time is. Roughly, we calculate from them ovulation time and ask them to wait. And number two, if we find any cause, then treatment of the cause is given. Number three, if we find problems, hormonal problems, and ovulation is not happening, in such patients, induction of the ovulation is done and patient is being monitored. Number four, in some patients where sperm quality is not good, but lady has patent tubes, we can do artificial insemination, IUI, which is done in our OPDs. And it doesn't need any special expertise. It needs only ultrasound and the person who gets this semen preparated, even if semen quality is low, get it concentrated, semen preparation washing is done, and then artificial insemination is done at the time of the ovulation. No expertise needed. Then the last is IVF or ICSI. It needs special expertise, and this patient is to be sent to a who is expert in IVF. Patient needs to be sent for that. Now we'll read the next slide and I'll talk about that. How do we do the basic when an infertility patient comes to us? How do we do the basic workup? Basic workup means we take, again, this is the repetition of the same, take a detailed history, physical examination, because it is done combined, both partners. Semen analysis, day 2-3 hormones are done. Day 2-3 means when she gets periods. Second day or third day hormones, when we get the clue of her ovulation. Then day 21 progesterone. This also gives us that a patient's hormones are, ladies' hormones are fine. She is ovulating. Her susceptibility to rubella, has she been always before getting pregnant? Rubella IgG should be checked whether she is immune. Has she received MMR in the past? If she has received, her IgG will be positive. If not, then she is given MMR before 3 months before getting pregnant, when pregnancy is being planned. Also, we check serum prolactin and thyroid function tests, and some basic screening, which again in the OPD can be done for the local factors like cervical smear screening and screening for other common infections in the vagina, which is chlamydia and trichomonas. Next. Now, advanced investigations, there are few advanced investigations which, after doing the basic, they are recommended in more than 35. In addition to basic investigations, we consider these investigations also. What it tells us about we have to check, be authentic about the ovarian reserve. As we know, with age, ovarian reserve decreases and chances of pregnancy become less. So how do we do that? There is a hormone which is called anti-Mullerian hormone secreted by the ovarian cells. We measure it and get the clue of how the ovarian reserve is. Then it can be checked also by ultrasound, a special ultrasound which is done on immediately after the second or third day of periods, and we see the follicular count in the ovaries. This gives us idea of the ovarian reserve, how it is the ovarian count, particularly of high importance of the patients in over 35, because we can't afford to waste more time. Next. In some cases, we may have to do laparoscopy also for the diagnostic, and it can be therapeutic also in some cases. Laparoscopy, when we do laparoscopy, we put laparoscope in, we can confidently diagnose that it is a case of endometriosis. It is the confirmatory diagnosis of this endometriosis. Though in endometriosis, tubes may be patent, they may not be blocked by tubal test by earlier. It may show us the tubes are patent. By putting in scope in the abdomen, we diagnose endometriosis. Tubes may be patent, but their function is lost as they are not working properly because of the endometriosis, though we may falsely see that they are patent. So how it is therapeutic? If there are some adhesions or something, we remove those adhesions. If ovaries are too polycystic, we can do some drilling, and there are any fibroids, they can be removed through laparoscope only. And also hysteroscopy also has a role. Hysteroscopy, in hysteroscopy, we can evaluate the uterine cavity. Hysteroscopy is we put a scope through the cervix into the uterus, and we can see the uterine cavity. Sometimes we miss on ultrasound, there's intrauterine septums. If we find such septums, we can remove those septums through a hysteroscope. So again, it is diagnostic as well as therapeutic. In case of failed IVFs also, it's of great value to see. Sometimes we are this IVFs fail because there are some undiagnosed septums, small septums, which can be removed through this. Next. Now, male factors, surgery, medical management is not, there's not much of the medical management if the semen analysis is not abnormal semen analysis. Of course, if there's any infection, we can treat it, but definitely surgery has a role. If there is any block, semen is not coming because of any block, that block can be removed, and this part is done by urologist, not by us. And also it has a role in if there is a retrograde, sometimes there is retrograde ejaculation, it has a role in that also, and such patients are being referred to urologist who takes evaluates them and takes care of them. They are not being managed by a gynecologist. Next. So we will take them. I have written treatment of the cause just for easy understanding. Like if we have unexplained infertility means that apparently everything is fine with both partners. We don't find any deficiency in either, but still they are unable to conceive. In such cases, some people give ovarian hyperstimulation, but that doesn't improve pregnancy rates. They are asked to conceive by given advice about ovulatory period and other things. If still they don't conceive in 2 years, and especially they are in advancing age, without wasting time, they should be asked to go for IVF. Next. There's another group of patients where we find certain causes, like tubal factor is there, or as I told you that uterine factors are there. Tubal surgeries are done. Any treatment is better than no treatment, but they are not of much success rate is not there. Many have been tried, like febrile dilatation, catheterization through hysteroscope, cannulation. Not of much success rate is not there. Uterine surgeries, of course, there is a role if there are intrauterine adhesions, and I told you septum also. Ladies gets, I mean, there is amenorrhea due to these adhesions. We can remove through hysteroscope these adhesions, and this may help in some cases where these adhesions are responsible. She starts menstruating, naturally we can induce ovulation and it may help. But tubal surgery as such doesn't have much of the role. Next. Now, but one of the important causes we said, and the management, we said the ovulation induction. Oh, there are, but the main cause is the ovulation. Majority of the cases in the ladies, where we said 33% are the female causes. Ovulation disorders is the main group. Again, it has been classified into three groups: group 1, group 2, group 3. Group 1 is where there are causes from the hypothalamic pituitary, that means from the brain. In such cases, you will find that patient has amenorrhea, and the genitals and other organs are not well developed, what we call hypogonadotropic hypogonadism. Number, for them also we can't do much. Group 2 is hypothalamic pituitary ovarian dysfunction, which usually happens in polycystic ovarian syndrome. Here, induction of the ovulation has a great role, and we can help them, and they usually conceive if the treatment is given. Group 3 is ovarian failure. In ovarian failure, again, we can't do medically much, but if there is still some reserve is left, immediately without wasting any time, IVF is advised. Next. Now, as we talked of group 1, the cause is in the pituitary gland, central cause. Here we can't do much. Patients present with amenorrhea, and once we diagnose that it fits in group 1, cause is in the pituitary, in the upper central nervous system, upper. So such patients usually you find are very thin and lean. BMI is less than 19. We try pulsatile gonadotropin releasing hormones or gonadotrophins with luteinizing hormones activity to induce ovulation for them, certain hormones, but not much of a success. Number 2, next. So our aim is on these patients, group 2, which is mainly we call it PCO, very, very common. Every 8 out of 10 girls, we find that this is the cause of the infertility, especially due to age and stress, environmental factors, lifestyle changes. This is the major cause of the infertility nowadays. So how do they present with us? They have weight loss of weight of our aim of the treatment should be that their obesity should be brought down, then 30 BMI should be brought down. So they have to be advised on diet, exercise. That are the key factors. Only medication will not help. Second thing, I usually put them on metformin because somewhere they have hyperinsulinemia, and metformin helps in the weight loss also. And quality of it is not prone, but metformin may increase quality of eggs also, because PCO patients, if they conceive, they are more prone to get miscarriages. I have seen that metformin really helps them. This is my personal experience, and metformin is a routine for me in PCOs who are trying for pregnancy, as with advice for obesity, how to lose the weight, how diet should be given, diet chart, they are being given diet charts, advised exercises. Then metformin forms a part of the treatment along with the folic acid. And then we think of inducing ovulation in them. There are two medicines. Initially, we were using clomiphene citrate, which we call clomid, clomiphene citrate, and monitor their ovulation by ultrasound. And usually it success rates are very high. If this clomiphene doesn't work, then nowadays we have, which is a chance finding, nowadays we use letrozole. Letrozole was a medicine which is aromatase inhibitor. It was started given in postmenopausal breast cancer, with the aim that it will act as anti-estrogen, and so that breast this cancer is not recurrence, doesn't occur. But here it mimics the action of clomiphene without the side effects of clomiphene. So it doesn't have the same side effects of anti-estrogenic. So we use it here also. Nowadays, we have switched on from in clomiphene citrate, this resistant cases. And as such, clomiphene citrate has anti-estrogenic effects. So we have switched on to letrozole for the induction. This is the basic induction we do. In those patients where it doesn't work, then we may have to give follicular stimulating hormone, but everything is being done under the guidance of the ultrasound to see that there is no this hyperstimulation. And whenever there is ovulation time, we give a trigger. Everything is being followed in ovulation induction. First, we give clomiphene citrate or letrozole. As I told you, now we have switched on to letrozole. Once the ovaries are sensitive, they respond and ovulation can occur. If we don't find any success, we go to gonadotropin hormones, give them gonadotropin hormones. So usually these patients of polycystic ovaries, this is the way we are able to help them, and we are following them with ultrasound for the ovulation and conception rate they usually conceive. Next. Now there is one, as in PCOs, we have divided them into three groups. Group 2, I said, is the most common, which I have discussed with you. Another ovulation disorders where everything could be normal, but there is prolactin level is high, hyperprolactinemia. These also, they don't ovulate and present with infertility. When we investigate them, we find that they have hyperprolactinemia. That means prolactin hormone is high. And what is the cause of hyperprolactinemia? It comes from pituitary gland. So we have to rule out other causes. There is no tumor and everything. And when we are convinced everything is fine, we put them on dopamine agonists such as bromocriptine. It works wonders. In 3 days, prolactin level comes to the normal. And in the meantime, we do ovulation induction. They become with such simple treatments. It helps a lot. So that mainly we have to treat the ovulation disorder, or they ovulate and they become pregnant under our guidance. Next. We discussed here there one of the causes, endometriosis. Endometriosis is, as the name itself says, it is the endometrium reversal of the menstruation has been happening without ladies' knowledge, and the endometrium is present over ovaries, tubes, and inside it creates havoc. It damages tubes, it damages ovaries. Ovaries can present with cysts, chocolate cysts or hemorrhagic cysts, tubes and everything, and patients present with infertility or painful menstruation. Here, medical management doesn't help much for the treatment of this infertility. Medical management is only for young girls where we suppress the ovulation. So, in for the main management of the pregnancy, if we want, lady wants the pregnancy, we have definitely, for even mild or moderate cases, we need to put a laparoscope and release her adhesions. Wherever the adhesions are there, release the tubes, make them, our aim should be to make the tubes functional. And at the same time, if there are any cysts, usually there are cysts present in the ovaries, they are removed, and with the preservation of ovary, we have to be very careful. The only to be removed those endometriomas if they are more than 4. Otherwise, we leave if the smaller. So the aim is we don't damage the ovaries, and later on we can put them on medical management, ask them to become pregnant as early pregnancy. As soon as they become pregnant, and this endometriosis is the hyperestrogenic effect. Pregnancy has the cure rate for them. I can't say cure, but the reversal can happen if the pregnancy is itself a cure rate for them. Next. As I already told you, the tubal factors, and maybe more effective is not more effective, but at the same time, any treatment better than no treatment. But it is again in the expertise. There is should be special expertise. Very few people where we refer such patients, but not with much success. Of course, with uterine surgery, when we put the hysteroscope, whether it is through laparoscope, removing my small fibroids, or hysteroscopic adhesion releasing, improve their menstruation, improve their chances of pregnancy are improved. There we can help them. Next. Also, in the tubal and uterine factors, I would say that sometimes before IVF, once we refer such patients to IVF, or there is indication for IVF, we that time also we find some patients are diagnosed on simple hysterosalpingogram that they have hydrosalpinx. So before referring them, we try to do surgery for these hydrosalpinx so that these in with IVF treatments are successful. It's always important to remove such tubes, to do surgery for hydrosalpinx tubes, so whether it is both or one, both tubes are removed, and that increases the success rate of IVF treatments. This is done through laparoscope before doing any IVF. This IVF and ICSI rates, success rates increase. Next. We know that infertility has been a problem throughout history. However, increasing rates are noticed now because of late marriages and environmental factors, stress, too much of stress, but too much of weight, obesity, or too much of anorexia nervosa, both extremes. And as we know, the first successful birth of a test tube baby Louis Burn, which you can see, occurred in 1978 in Oldham General Hospital, UK. Since that, we have had many advancements in the IVF in our own country. In Delhi, we have many centers where every day this is being done routinely now. And who was the physiologist? Robert G. Edwards. He developed the treatment. He was the one who developed, and he was awarded the Nobel Prize in Medicine in 2010. Thank you very much. I hope you liked it. Any questions or anything, I would be happy to answer them.
Madam, what is the role of the DNC and DNA?
Sorry?
Role of the DNC and DNA. Dilatation. Many times
sorry, say it again, please.
Many times the gynecologist asks the patient to do the DNC and DNA for the non-conception.
DNC is the diagnostic DNC to see the this hormonal status. Like it is done premenstrual. If we do premenstrual DNC, take this biopsy from that, we should be able to see the secretory changes. If you see secretory changes, that means the patient has ovulated. Progesterone formation is there. There are two phases of menstrual cycle. One is this luteal phase, that is secretory phase due to the corpus luteum. So if we find proliferative phase in the premenstrual phase, that means lady has not ovulated. So it is the evidence of ovulation.
At what age the conception should be tried by the couple?
Sorry?
What is the most satisfactory factor that is responsible for the conception? At what age the male and female should marry, and they
yes, of course, like before this, less than 30 would be the ideal for the completion of the family. So after 20, that are the best years. But we know in the current scenario, it is not possible. Everybody marries at 3. So there is too much of interference with the nature. So ovarian reserve decreases. We know with age, we are born with ovarian reserve, which is a basket of eggs, really. And with time, it decreases. So the best age would be less than, in the current scenario, also less than 35 would be the best. But we are getting patients at 38, 39, 40, and we can't afford to waste time. And they are not ready for IVF also. IVF also, there is no guarantee that they will go at success rate with age for IVF also decreases. आजकल के टाइम में तो that is gone, reproductive years are gone, making career, things have changed. In our times, even if we were doing our post graduation, we would say no, we don't want to marry, but the marriage was the first thing, then career comes second thing. Your education will be later, first marriage. But nowadays it's totally opposite.
And what is the treatment of the choice in the azoospermia in male?
Azoospermia, first we have to see, most of the times when patients come, we do semen analysis, this comes azoospermia. But when we refer them to urologist, we are surprised to see that there are obstructive causes. Once the obstructive causes are ruled out, then you have to counsel the patient. It's not an easy thing to accept. You have to counsel together. It takes a lot of time for counseling. If they accept for then donor or adoption, one of these. And I have seen most of the patients, egg donation, they are ready, but sperm donation, most of the couples are not ready. So it has to be counsel them for adoption.
How the anti-mullerian hormone affects the uterus?
It doesn't affect the uterus. Anti-mullerian hormone comes from the granulosa cells. It's a different hormone. It doesn't come from any other, or it comes from the granulosa cells of the ovary. And it gives us that is how we evaluate this basket of ovaries. What is the reserve like? It is the reserve. And with age, it goes on decreasing because reserve decreases. It doesn't give us the what are the quality, but it gives us it is the indicator of reserve.
Yes.
It comes from the granulosa cells of the ovaries. But always we do, and if we do at the age of 25, 24, it will be very high, very nice. And if we do it after 35 years of age, it will be very less, and then the chances of conception also become less. That gives us an idea of ovarian reserve. So we should be, without wasting time, if there are some factors, without wasting time, they should be asked to go for ART.
And what about the hypospermia in male treatment?
Which treatment?
Yes, if the patient has hypospermia, what is the oral medication?
Oh yeah, yes. For them, there is the best treatment is IVF, and among IVF, the ICSI is the best. What we do is IVF, that sperm and this egg is fertilized, that embryo is being implanted. In ICSI, in low hypersperm count, in ICSI, the direct sperm is put in intracytoplasmic. There is treatment for that, for low sperm count. Yes. And also in azoospermia, many patients have turned out to be azoospermia after semen analysis. And once we refer them to you, because we don't see such patients, refer them to urologists, after they have found some obstructive causes for them, obstructive, and after some time they come back with, there are some sperms, there are some cases like that. So we should not at once, no, don't label any patient as a spermia until a urologist says that patient, for to rule out obstructive causes.
And what is the effect of the alcoholic beverages, smoking, and
Oh,
obesity?
smoking and this alcohol alcohol in moderation is okay. I wouldn't say everybody should be, but definitely alcohol intake, smoking, diabetes, drugs, occupation, especially those who are wearing those working in those hot areas, and scrotal, scrotal heat to reduces sperm quality.
Many patients suffer from the tuberculosis of the fallopian tube.
They do, and
And
yes, they do. That is why fallopian tube, I didn't take it separately, but tubal factors, they are the main cause of tuber blockage. When we do for any lady, it's simple, we don't directly take them for laparoscopy. We do this hysterosalpingogram. When you see this tubal factor, both tubes are, then for confirmation, of course, we may do laparoscopy. And the cause is tuberculosis, and there is no other alternate except IVF if they can afford. It's not easily affordable and easily available. It comes with big money.
many patients conceive after taking the treatment of the AKT.
Sorry?
Is it right?
Sorry?
Many patients cured with the AKT treatment, anti-tuberculosis treatment, when they have the fallopian tube tuberculosis.
You
And
see,
they
anti-tubercular treatment is fine, it is okay, but usually it is very difficult because tubes what happens that tubes are once damaged with cilia and other things that is damaged, they are very, that anything can happen, we can't say 100% absolute no, but tubes are a very delicate thing, cilia and everything is done, it's not blockage only, they may be functional, they may be open, patent, but they are not functional most of the time. But rare cases, it may happen. Anything is possible. Anything is possible.
varicose is a factor for the infertility in male.
Varicocele, of course, yes. Varicocele is a factor, yeah. It is.
If anybody has any more questions, please. Ma'am, I think questions have been asked. So
Okay.
thank you so much for coming on our platform, ma'am. I'm truly grateful.
Thank you. Yesterday, Dr. Veena told me, I said, who will be interested in infertility? So she told me, you talk. I said, okay, I'll talk on infertility because this lecture was already prepared for PG students, for postgraduate students. I had already given this lecture. I said, okay, I'll give this. So whether it was of any interest or not, but anyway, some of us heard.
Madam, this is a nice lecture and it's informative also.
Very
This,
interesting.
Yes.
this I had given to PG students, so I got a short notice, but I was myself laughing. I said, we are missing Dr. Nidhi, but okay, I will give, my lecture is ready. There is no harm. I'll talk. She was very keen. I talk on infertility. I said, I'll do that.
It was very interesting, ma'am, especially for people my age, for the youth. We should know all of this.
चलो एटलीस्ट किसी को तो अच्छा लगा, बट
बिल्कुल, बिल्कुल,
ये
ma'am.
स्टूडेंट्स को ही अच्छा लगता है सुनना.